Namaskar, one and all. Warm greetings from Dental Council of India. I'm addressing from College of Dental Sciences, Bapuji Educational Association, Davangere, which is situated at the central part of Karnataka. On behalf of DCI President Dr. Mujumdar, I welcome all the undergraduates, postgraduates, practitioners, academicians for the 12th webinar of the series. So nice to have each and every one of you as our esteemed participants for this live webinar. First and foremost, I hope all are staying healthy and safe. Need for education never stops. I take this opportunity to thank Dental Council of India for their timely initiative for hosting the series of free webinars and promoting e-learning. I would like to extend my heartfelt gratitude to our DCI President, Dr. Mujumdar, Under Secretary Dr. Saha, and other team members for their visionary idea of hosting the series of webinars. These webinars are bringing the entire dental fraternity together, not only along the length and breadth of India, but also across the globe. Before we move to the introductory session, I would like to make an announcement regarding the instructions for the webinars. All the attendees have to furnish the complete and the proper details. No request for any change or a modification in the details shall be considered later. An e-certificate of the attendance will be sent to all eligible candidates on their registered email. CD points will be awarded to the dentists who are registered, and certificates will be sent to the attendees by mail within 3 days of conclusion of each webinar who have attended the entire session of the webinar uninterrupted. Also check your junk email folder for the certificate in case if it is not delivered to your inbox. Dental Council of India recognizes the top 5 dental colleges with the highest attendees of the last webinar. The first one goes to Saraswati Dental College, Lucknow. Second is the St. Joseph Dental College, Andhra Pradesh. The third one is the Sibara Institute of Dental Sciences, Andhra Pradesh. The fourth one is the Indraprastha Dental College and Hospital, Ghaziabad. The fifth one is the Guru Nanak Institute of Dental Sciences and Research, Kolkata. Congratulations to all the colleges. Today, I take this privilege to introduce our esteemed speaker, Dr. Kirtilata Pai. I'm delighted to inform all of you that Dr. Kirtilata Pai and myself are the alumni of Government Dental College and Research Institute, Bangalore. Dr. Kirtilata has done her post-graduation in the specialty of oral medicine and radiology, and at present she is working as Dean at MCOTS, Manipal. She has an immense passion for teaching. She has more than 175 publications, and she is a reviewer for many prestigious national and international journals. Dr. Kirti has done her observership at Loma Linda University, California, and at University of Minnesota, USA. She has received multiple prestigious awards like H.D. Millard Award for the best publication in O Journal in 2008. She has also been awarded as a distinguished research faculty by the Career 360. She has been conferred with the Best Teacher Award by the Manipal Academy of Higher Education 6 times. And there are many more achievements to her list. It's a great pleasure to have Dr. Kirtilata Pai on this DCI webinar platform. Today's topic is adverse drug interactions and the effects, what every dentist should know. We prescribe drugs in our day-to-day practice. There are 3 possible actions of the drug. The one we want, the one we do not want, and the third one we don't know about it. The drug interactions and the effects is a real challenge in the modern healthcare because of polypharmacy, increased geriatric population, as well as because of self-medicating practices. It can mimic any disease and is the 6th leading cause of death worldwide. In spite of quite advances in the research and technology, adverse drug interactions and the effects still remain challenge to the healthcare professional. Today's presentation takes you through the key facts about the adverse drug interactions and their effects and explores its mechanisms, oral manifestation, prevention, and pharmacovigilance, that is detecting, recording, and reporting of adverse drug reaction. It's over to you, Dr. Kirti.
Thank you, Dr. Rajeshwari, for the kind introduction. Dear viewers of DCI webinar from India, good afternoon. For those of you who have logged in from the East, good evening. And to those of you who have logged in from the West, good morning. I take pleasure in introducing the moderator of this webinar to you all. She is Dr. Rajeshwari G. Annigeri, the Professor and Head, Department of Oral Medicine and Radiology, College of Dental Sciences, Davangere. She has passionately involved herself in tobacco awareness programs and covered over 42,000 people. She has received the Lifetime Achievement Award from Helpline Rural Development Organization. Congratulations to you, Dr. Rajeshwari. I'm extremely happy to share this virtual platform with her. My heartfelt thanks to the Honorable President of Dental Council of India, Dr. Dibyendu Mazumdar. Also, to the Honorable Secretary, Dr. Sabyasachi Saha, for this great honor. I bring warm greetings from Manipal Academy of Higher Education, an institution of eminence. This status was conferred by MHRD Government of India in 2019. I bring warm greetings also from my institution, Manipal College of Dental Sciences, Manipal. Medicinal drugs have a special place in the armamentarium of management of diseases, provided they are carefully chosen and used. I say this because drugs are like double-edged weapons. They have beneficial effects when used in the right patient, for the right indication, in the right dosage, and through the right route. In spite of this, a given drug on its own can have adverse effects when it interacts with different systems in a given individual. Moreover, the adverse reactions get compounded when drugs interact with each other or with other substances in an individual with systemic disorders. I will illustrate to you this fact with some examples. So let us take up this case 1, a 72-year-old male with acute periapical abscess in relation to lower molar. He was a known hypertensive on captopril and thiazide diuretic. He was prescribed augmentin and ibuprofen for 5 days and advised to report for further management. But this happened during the COVID times. He could not return for management, so he continued on his own with the second dose of the medications. 10 days later, he was hospitalized with weakness, loss of appetite, and facial swelling. He was diagnosed with heart failure and pleural effusion. His blood analysis revealed high levels of creatinine, which was suggestive of acute renal failure. So if we analyze this case, did this all happen because of the acute periapical abscess? Not at all. He was prescribed ibuprofen in the dental practice, which interacted with captopril and thiazide diuretic, which was used for the control of his hypertension, and this resulted in a triple whammy effect. Let us take our case 2 now. This was a 65-year-old female with acute periodontal abscess. She was a known diabetic receiving dianyl therapy. She was prescribed amoxicillin and metronidazole with ibuprofen for 5 days, and like our previous case, she took a second course. On day 8, she collapsed and was rushed to the hospital, where she was diagnosed to have profound hypoglycemia. So let us analyze this case. Metronidazole was prescribed for a periodontal abscess, which interacted with dianyl, a sulfonylurea, and this interaction resulted in increased blood concentration of dianyl, leading to severe hypoglycemia. We will see our third case now. This was a 40-year-old male, totally healthy. He had no medical problems. He had just toothache, for which he was prescribed paracetamol, as is the routine case. He took just one dose of paracetamol, but promptly he reported to emergency next day, and he looked like this. He had high fever, he had skin rashes, his oral cavity was completely denuded. So diagnosis for him was drug-induced Stevens-Johnson syndrome. So all these cases tell us that the drugs prescribed in dental practice could lead to severe drug interactions, or just one drug can lead to an adverse effect which can be very serious. So that brings me to my topic, adverse drug interactions and effects, what every dentist should know. But before I go into the topic, details of the topic, let me give you an overview of the drug scenario in our country. There are more than 20,000 approved prescription and over-the-counter drugs in our country. In addition, there are hundreds of herbal and dietary supplements that hardly undergo any scrutiny by drug controlling authority. Then there are scores of alternative medicinal drugs like Ayurvedic, homeopathic, Siddha, Unani, so on and so forth, about which we dentists have hardly any knowledge. To make the things worse, patients often think it's not necessary to disclose their medical illness or medications to the dentist. There is also a change in the patient profile in dental practice. We are now seeing more elderly patients that are taking various drugs for non-communicable diseases. Life expectancy has improved now after the advent of antibiotics. Earlier, elderly patients would come for dentures, but now there is a paradigm shift in the dental needs. Elderly patients are opting for more complex procedures, including implant placement, and this necessitates the administration of drugs such as local anesthesia, antibiotics, anti-inflammatory agents, and even anti-anxiety drugs. To add to that, there is an increase in the number of younger patients with diabetes, hypertension, and cardiac disease, and they are also receiving medications. So all this increases the risk of adverse drug reactions and interactions and effects in dental practice. I will take you through my presentation in this order. We will first look at what is drug interaction and what are its types. We then will look at the mechanisms of drug interactions. We will see who is at risk of developing drug interactions. Then we will look at the adverse drug interactions and adverse drug effects seen in dental practice. And finally, we will see how to avoid adverse drug interactions and effect practice. Drug interaction is defined as a change in the activity of a drug caused by concomitant administration of another substance or presence of an underlying condition. We'll see the types of drug interaction. A drug can interact with other drugs taken by the patient. The drug can interact with the food that is consumed by the patient, can interact with the supplements the patient may be receiving, or can interact with underlying medical condition. And from these interactions, what could possibly be the effects? They could be a decrease in the action of the drug or drugs, resulting in their reduced efficacy, or there may be an increase in the action of the drugs, resulting in their toxic effects, or there can be adverse effects. So we will look into these interactions one by one. We will first look at drug-food interactions. Most of the oral drugs are best given with or after food, but there are certain medications in dental practice which should be given at least 30 minutes before food. and include the most commonly prescribed paracetamol, tetracycline except doxycycline, erythromycin, serratiopeptidase. In fact, serratiopeptidase has to be administered at least 2 hours before meals or on an empty stomach for it to have action. Tetracycline with milk. Let us see what happens if tetracycline is taken with milk. We know that milk contains calcium, so tetracycline will chelate with calcium. So milk will delay the absorption of tetracycline, as is seen in this graph. When tetracycline is taken with water, the peak tetracycline blood levels are much higher than when it is taken with water. So this should be borne in mind when we are prescribing tetracycline for our patients. Next, coming to warfarin, it's a very common medication with multiple medical indications. This drug acts by inhibiting vitamin K synthesis. So if food which is rich in vitamin K is taken by the patient in abundance, it can inhibit the action of warfarin, thus increasing the risk of thrombotic events. So patients should be advised not to take these foods which are rich in vitamin K when warfarin is administered. Grapefruit orange juice are promoted as health drinks. This has anti-cancer property and is becoming popular. But we must keep in mind what interactions it can cause. The drug Allegra, which is fexofenadine, a non-sedative antihistaminic, is often prescribed by us for allergic reactions. This drug can be affected by grapefruit juice and its levels may be decreased because the intestinal absorption is hindered. This leads to its reduced effectiveness. While if the patient is prescribed atorvastatin and takes it with grapefruit juice, it can lead to its decreased metabolism by the liver, resulting in its increased blood levels, causing liver damage and a serious condition called rhabdomyolysis, which is characterized by skeletal muscle damage. It can also lead to kidney injury. While that was with non-alcoholic beverage, alcohols also can interact with the drugs, causing serious reactions. Metronidazole is a common drug we prescribe in dental practice for anaerobic infections. And if the patient concomitantly takes alcohol, there can be a disulfiram or antibuse-like reaction, which is characterized by nausea, vomiting, abdominal cramps, headache, and flushing. So it's extremely important that we advise our patients who we prescribe metronidazole to abstain from alcohol at least for 3 days. But the reverse happens in case of paracetamol. If paracetamol is taken by a patient who regularly consumes alcohol, but for some reason decides to stop alcohol, it can lead to very high levels of toxic metabolites of paracetamol, which causes hepatotoxicity and severe liver damage. So it's extremely important to advise patients accordingly. So you have to take a proper history. And if the patient is an alcoholic, it is important to tell the patient not to abruptly stop alcohol consumption because it can lead to serious adverse effects. Now we go on to drug-herb interactions. Herbal remedies are becoming very popular. Patients have overbelief or blind belief on some of these herbal remedies. But we have not much of knowledge about the active ingredients of these herbal remedies, and we do not know their mechanism of action. Let me give you an example. St. John's wort is popularly used as an antidepressant. It is available over the counter, and if the patient is concomitantly taking warfarin, it can result in a reduced efficacy of warfarin and increase in the risk of thrombotic events will be there. While if the patient is taking calcium channel blocker verapamil, which is also an anti-anginal medication, with this herbal preparation, there can be decreased level of verapamil, resulting in increased BP and risk of anginal attack. So it is very important to take a proper history from the patient, not just about the drugs that the patient is receiving, but also about the herbal medications which the patient may be taking. It's extremely important also to tell such patients not to take the herbal remedy at least for 7 to 14 days before an invasive procedure or surgery. The next interaction is a drug to disease interaction. This is when the drugs worsen or exacerbate a pre-existing disease. Let me give you some examples here. When NSAIDs are taken by a patient with asthma, it can result in bronchospasm, while patients with peptic ulcer disease will have gastrointestinal bleeding if they take NSAIDs. Nicotine is commonly prescribed for patients who want to discontinue their tobacco habit, and when they are not able to do it on their own, we give them nicotine patches or nicotine products. And if that is prescribed to an hypertensive, it can result in tachycardia and its consequences. The next interaction is drug-to-drug interactions. Now, drug-to-drug interaction is a situation when drug affects the activity of another drug already taken. So the drug which causes the interaction is called a precipitant drug, and the drug which gets affected by the interaction is called the object drug. Now, if you recollect our second case, the lady who developed hypoglycemia when she was prescribed metronidazole, metronidazole is the precipitant drug because it caused an abnormality in the levels of the object drug, which in the case was dianine. What will be the outcome of drug interactions? The outcome can be good sometimes, where the combination of the drugs may increase their effectiveness or decrease the toxicity of individual drugs. It may be bad more often, and that is because there is a decrease in the effectiveness of the drugs, or there is an increase in the toxicity of the drugs. So we have seen what is drug interaction and what are the types. We will now go on to see what are the mechanisms of drug interactions. There are three mechanisms of drug interactions. The first one is a pharmaceutical interaction, where the drugs react with each other when they are mixed outside the body, that is in vitro. The second mechanism is a pharmacodynamic mechanism, where one drug acts on another drug at its target site, that is where it has to have its action. In this case, there is no change in its blood levels, that is, there is no change in its concentration. Whereas the third mechanism is a pharmacokinetic mechanism, where one drug affects either the absorption or the distribution or the metabolism or elimination of the other drug, ADME to remember it more easily, and there will be a concentration change, or the blood levels of the affected drug will change, resulting in its adverse reactions. So as said, pharmaceutical interactions are in vitro interactions where injectable drugs are mixed either in the same syringe or in the infusion bottle. The example is, if we mix gentamicin with carbapenicillin, there will be inactivation of gentamicin. Sometimes we may think, why give two injections? Let us mix the drugs and give. But if the drugs interact with each other, that will be a problem because the drug may get inactivated. And if heparin is mixed with hydrocortisone, there is inactivation of heparin. So these should be borne in mind if at all you are considering mixing of two drugs, that there can be an interaction, which is a pharmaceutical interaction. The next interaction is a pharmacodynamic interaction, where we can have a synergistic type of interaction, where the therapeutic or toxic effects of two drugs is greater than the sum of their effects, where 1 + 1 is more than 2. A good example for this is a combination of trimethoprim and sulfamethoxazole, which is available as Bactrim or Septran. This is a good combination because the effect of these two drugs will be more than the sum of their individual effects. Next is the additive pharmacodynamic interaction, where the therapeutic or toxic effects of two drugs is equal to the sum of their effects. That is, 1 + 1 is equal to 2. So we often combine ibuprofen and paracetamol to get an additive effect, to get more pain relief. The third type of interaction is an antagonistic interaction, where the therapeutic or toxic effects of two drugs is lesser than the sum of their effects. So 1 + 1 maybe less than 2, it may be 0 also, or it may be just 1. So good example is the interaction between warfarin and vitamin K, where there is a reversal of their actions. Next is pharmacokinetic interactions. Let me spend some time here to tell you about the drug cycle. The drug, in case of per oral administration, will go to the stomach. There it has to be absorbed. Some amount of absorption also in the small intestine, and then it will enter the bloodstream. In the bloodstream, the drug will get combined or bound to the plasma proteins, and the drug which is not bound to plasma protein is the free drug, which is available for its action at the target site. Then the drug is carried to the liver, where it gets metabolized, and then it is sent to the kidneys, where it gets eliminated. So in pharmacokinetic interactions, there may be modification of the action of a drug by another drug by affecting its absorption or its distribution or its metabolism or excretion or elimination. So by affecting any of these steps, the blood level of the drug may either be increased or decreased, thus causing the adverse effect. So we have looked at the first two. We will now see who is at risk of developing drug interactions. The risk factors for drug interactions can be considered under patient-related risk factors, which include extremes of age. Patients who are very old or very young are at more risk of developing drug interactions. Patients who are very sick, where their physiology is severely affected, the drug metabolism will be affected, and they are at more risk of developing drug interactions. Patients with multiple comorbidities and those receiving multiple drugs are at more risk of developing risk factors. So also patients who are having liver compromise or renal function abnormality, they will have more chances of developing drug interactions. We will now see what are the drug-related risk factors. Drugs with narrow therapeutic index. About this, I will tell you in the next slide. Drugs which have high affinity for plasma proteins. I explained to you that in the bloodstream, the pharmaceutical agent gets bound to the plasma proteins, and whatever is free is available for its action. So if there is another drug which has high affinity for plasma proteins, it may displace the drug which is bound to the plasma protein, thus increasing its free level and its toxicity. Then there are certain drugs which are enzyme enhancers or inhibitors. For example, carbamazepine, which we normally give for treatment of neuralgias, it is an enzyme enhancer, or it activates the liver enzymes. That enzyme is cytochrome P450. So carbamazepine enhances the action of this enzyme, thus increasing the levels of the drug, whereas some drugs can be inhibitors of the enzyme. The next is long-term use of drugs also can be a risk factor for drug interactions. And finally, simultaneous use of two drugs for the same disease increases the likelihood of developing drug interactions. So you can see in this graph, when two drugs are taken, the likelihood of drug interactions is 6%, but when the number of drugs is increased to 5, it becomes as much as 50%, and with 8 or more drugs, the risk is 100%. Next, about therapeutic index, it is the margin between the effective dose of the drug and the toxic drug. There are certain drugs which have a very narrow margin between their effective dose and the toxic dose. So if due to some reason there is slight change in its concentration in the blood, the drug may reach its toxic level. Example for this is digoxin, which is used in cardiac failure. It has a very narrow therapeutic index. So if due to some reason there is decreased excretion of digoxin due to some renal problem, then the level of digoxin in the blood will increase, resulting in its toxicity. So we looked at the risk factors. Now we will move on to adverse drug interactions. Many of our patients are taking drugs for their medical ailments and may include thyroid hormones, anti-diabetic drugs, antihypertensive drugs, proton pump inhibitors, lipid regulators, antiplatelet drugs, anticoagulants, antidepressants, beta-2 agonists, medications for osteoporosis, and also steroids. So patient may be receiving any one of these drugs or may be receiving 2 or 3 or 4 or 5. So there can be patients receiving as all the drugs also maybe some patients are receiving. So we have already seen that more the number of drugs, more is the risk of drug interaction. So we will look at these interactions caused by the drugs taken for the medical condition with the dental treatment and also with the drugs that we prescribe in our practice. So we will take up these drugs one by one. So levothyroxine, as you know, is the replacement therapy given for patients with hypothyroidism. So it can have effects for dental treatment. Now, if the patient has been receiving levothyroxine for a long period of time and is having a stable dose, there is no interaction with dental treatment. However, if the patient has recently been diagnosed to have hypothyroidism and has been started on levothyroxine, then there are more chances of the patient developing arrhythmias, heart failure, and myxedema coma because of the stressful dental procedures. So it is very important that we defer the elective treatment if the patient has recently been started on levothyroxine. Let us see what are the interactions with the drugs that we prescribe. Carbamazepine is prescribed by us for the neuralgias. This is an enzyme enhancer. So it increases the metabolism of levothyroxine, thus reducing its blood levels. So patient may have to have the dose of levothyroxine accordingly adjusted. The next drug is ACE inhibitors, commonly captopril, lisinopril. This is used in the control of hypertension, very commonly used drug. So it can have certain effects for dental treatment. So routine dental procedures under local anesthesia can proceed safely in the normal protocol, but we need to keep in mind that the patient can have certain side effects. There can be postural hypotension. So we are very comfortable treating the patient on a supine position. Sitting dentistry is often preferred. But if we bring back the headrest to the vertical position, patient on captopril can suddenly collapse or faint because of the hypotension. So this should be borne in mind when you are treating a patient receiving captopril. There can also be very bothersome dry cough in these patients, which may come in wave with the placement of rubber dam, or even dental procedures may be very difficult because they have persistent dry cough. Another reaction that happens in patients with this drug is angioedema. Generally, it happens within a week of starting this, and this is a condition where there will be intense swelling of the lips and the mouth and the perioral region, and many times patients end up with a dentist thinking that it is some dental problem. So it has to be recognized as a medical emergency and suitable referral has to be done so that the patient can be immediately treated. Otherwise, there can be also breathing difficulty which may become fatal. Coming to interactions with the drugs that we prescribe, we have already seen this in our case 1, where the patient was receiving ACE inhibitor and on taking NSAIDs for more than 5 days, ended up having a triple whammy effect characterized by heart failure, pleural effusion, and kidney failure. So please remember that NSAIDs can be dangerous if given for extended period of time. The next agent is metoprolol, which is a beta-1 selective blocker, again a commonly used antihypertensive. This can have certain effects which are of interest for the dentist. Routine dental treatment, not much of interaction. You can do procedures under LA with not much of problems. But side effects could be same as captopril, where there can be postural hypotension, not to bring back the backrest straight suddenly, and keep the patient on the dental chair for some more time before he walks out of the operatory. There can be xerostomia, which will be in the form of dryness of the mouth, and patient can have severe discomfort in the mouth, speech problems can happen, and also the patient will have increased risk of developing dental caries. So it may be required sometimes to refer the patient to the physician to see whether this drug can be changed to a drug which is less likely to cause xerostomia. We will not change the drug because We do not know about the medical condition of the patient, but it is our responsibility to refer the patient back to the physician to change the medication if it is possible. There can be a bad taste or an altered taste sensation for the patient, which may bring him or her to you. So we must know that this may be because of metoprolol. So a drug history is extremely important. There also can be oral lichenoid reactions, which are lichen planus-like reactions in the oral cavity, which may cause soreness in the mouth. There can be a desquamative gingivitis. Patient may have burning sensation. So drug history is a must. Coming to interactions with the drugs that we prescribe, there can be interaction with NSAIDs. But while in case of captopril, we saw that there is hypertension with beta-1 selective blockers, NSAIDs will result in a hypotension because the drug levels will be increased, resulting in hypotension. Next group of drugs are the calcium channel blockers. Nifedipine, amlodipine are examples. These are very commonly taken by our patients for the treatment of their hypertension. So there is less interaction with dental treatment, but there can be side effects in the form of gingival enlargement. There can be xerostomia, and the interactions could be with the drugs like macrolide antibiotics. Normally in dental practice, we choose the penicillin group of drugs, but if the patient is allergic to penicillin and we have to choose some other group of drugs, we choose macrolide antibiotics. Erythromycin, clarithromycin, and clindamycin all can interact with calcium channel blockers. So also there will be interaction with grapefruit juice, which result in increased levels of calcium channel blockers, resulting in hypotension. So this should be borne in mind. If you have to give a macrolide antibiotic, you have to choose azithromycin and not erythromycin, clarithromycin, or clindamycin. The next group of drugs are statins, commonly atorvastatin and simvastatin, which our patients are commonly on. So coming to the effects on dental treatment, no specific interaction with the dental treatment. There are also no bothersome oral side effects, but with macrolide antibiotics, like that happened with the calcium channel blockers, there can be interaction with statins. Also can be with antifungals, which we commonly prescribe, like itraconazole and ketoconazole, leading to increased statin levels, which will result in a serious condition called rhabdomyolysis. Also, acute kidney injury may be there. Next group of drugs are the biguanides. Metformin is the commonly used biguanide for the management of diabetes. So when patients are taken up for dental treatment, there is no specific interaction with metformin, but we must keep in mind the side effects, which may be in the form of a metallic taste. Similar to what happens with metronidazole, there can be a bad taste in the mouth. Long-term use results in vitamin B12 deficiency, which we all know causes a balding of tongue. There is severe glossitis, which may cause burning sensation for the patient. And also this drug, like captopril, can result in angioedema, which is a medical emergency. As far as interaction with the drugs that we prescribe, there are no significant interactions. So here are the pictures of patients who developed angioedema due to metformin. You can see there is very severe swelling of the lips and the perioral region, and if it extends to the throat, there can be breathing difficulty, which may even turn to be fatal. Next group of drugs used in the management of diabetes are the sulfonylureas, more commonly glibenclamide, which is marketed as Dianyl. So there are no specific interactions as far as dental treatment is concerned. The side effect could be in the form of a tingling sensation around the lips or the tongue. So if a patient comes with this kind of a complaint, we have to ask about the history of intake of oral hypoglycemic agents like Dianyl. With metronidazole, remember our second case where the lady was given metronidazole for her acute periodontal abscess, which interacted with Dianyl, and she had a hypoglycemic attack. So this should be borne in mind when metronidazole is to be prescribed for a patient who is receiving Dianyl for management of diabetes mellitus. Now let us move on to the common drugs that we prescribe in dental practice. Since the most common complaint of our patients is pain, we prescribe analgesics more commonly, paracetamol, tramadol. And next group of drugs are the anti-inflammatory agents whenever the pain is of an inflammatory origin. And then is the antibiotics, and here we more commonly choose penicillin group of antibiotics because they are the best for the organisms that cause oral infections. But if the patient is allergic to penicillin, we may choose other antibiotics like erythromycin, ciprofloxacin, which is a quinolone, or metronidazole. We often use topical preparations like mouthwashes and topical gels, and proteolytic enzymes like serratiopeptidase are prescribed post-operatively to reduce the swelling. Now, coming to the drug interactions in dental practice, fortunately, they are rare because the duration of therapy in dental practice is generally short. We generally don't exceed for 5 days, and also the dose that we give is relatively small. At this point of time, I would like to bring to your attention that most of the medical conditions are long-standing in nature, and they require therapy lifelong. That means a patient who is diagnosed with hypertension is hypertensive lifelong and will require therapy lifelong. But that is not the case in case of our dental conditions. We have to give medications only for limited period of time. However, if the duration of therapy is prolonged, or if we prescribe large doses, as is happening in these COVID times, the patients may end up having serious drug interactions and adverse effects. Now, acetaminophen is the most popular drug in dental practice. It is the safest of all analgesics. There are no specific interaction except with alcohol, which I have already described to you. So in alcoholics, if acetaminophen is being prescribed, they should be advised not to abruptly stop taking alcohol. And if the patient is having liver disease, we have to be very careful not to exceed the dose beyond 2 grams per day. In a normal individual, we can go up to 4 grams per day. But in case of liver disease, we should not exceed 2 grams per day. Here, I would like to tell you that if paracetamol is administered to cats, they will die, because cats do not have the enzyme which metabolizes paracetamol. So a person with liver disease will have the enzyme system affected, and it will be very dangerous. So it can cause hepatotoxicity if you exceed the dose beyond 2 grams. Next is ibuprofen. This is the most commonly prescribed NSAID. But we should remember not to exceed giving this drug for more than 5 days. And caution should be practiced in many patients with medical conditions like asthma, peptic ulcer disease, hypertension, hepatic and renal disease. We have to be very careful with ibuprofen. This can have multiple drug interactions also, especially with antihypertensives, which we have already seen in our case 1. But sometimes we may have to give the drug for more than 5 days, especially post-operatively, we may have to give for extended period of time. Then we have to monitor the BP very closely. And if there is an increase of more than 10% above the baseline, it has to be replaced with paracetamol. Otherwise, there can be serious adverse effects. Although I have mentioned about ibuprofen interaction with other drugs earlier, I would again like to stress this because this is the most common NSAID prescribed by us. So if the patient is receiving beta blockers or ACE inhibitors or diuretics, then with ibuprofen, there will be reduction of the antihypertensive effect, leading to rise in BP and congestive cardiac failure. In patients who are receiving a combination of ACE inhibitor and diuretics, it results in triple whammy effect with pleural effusion and acute renal injury, as seen in our case 1. Lithium is a common antipsychotic drug that is used by our patients. Methotrexate is an antimetabolite commonly received by patients who have rheumatoid arthritis, and digoxin is a drug consumed by patients who have cardiac failure. If ibuprofen is given in these patients, the kidney elimination of the drugs will be reduced, resulting in their increased plasma levels and toxicity. Next is with anticoagulants, clopidogrel, which is an antiplatelet agent, selective serotonin reuptake inhibitors, which are antidepressants, and alcohol, there will be a risk of gastric hemorrhage. So it's extremely important. I'm stressing that we have to take a proper drug history. And if any of these drugs are consumed by the patient, we have to be extremely careful about prescribing ibuprofen. Next, what happens with aspirin? If the patient is receiving aspirin for its antiplatelet effect, there will be a reduction of antiplatelet effect, increasing the cardiovascular mortality and increased risk of myocardial infarction. Cyclosporin is a commonly used immunosuppressant. Patients receiving this, if they are given ibuprofen, there can be increased nephrotoxicity. General anesthesia. Oral surgeons have to note this point. If patients are on long-term ibuprofen therapy, surgery under general anesthesia increases the risk of patient developing hypertension. Patients may be receiving NSAIDs for their other painful conditions like rheumatoid arthritis. So commonly they are receiving NSAIDs like ketorolac or indomethacin. Over that, if we prescribe ibuprofen, it increases the chances of kidney damage. So this has to be borne in mind. Next group of drugs are the opioids. Commonly we prescribe tramadol. Usually it is given for moderate to severe pain, but we need to remember not to prescribe it when the dental pain is inflammatory in origin, because opioids are only pain relievers, they are not anti-inflammatory agents. Also, we need to remember not to give them for more than 3 days because they are likely to cause habituation and there can be abuse with opioids. And they are also classified drugs. There can be serious interaction with alcohol and also with antipsychotic drugs or the antidepressants, monoamine amine oxidase inhibitors, or selective serotonin reuptake inhibitors. We will see what interactions happen with opioids. With alcohol, as it is, alcohol makes a person drowsy. With opioids, the drowsiness will increase. There is a reduction of cough reflex, predisposing the patients to a risk of choking, which can happen also during dental treatment. There can be respiratory depression. So if you place a rubber dam, it may cause problems for the patient. Also, it leads to hepatotoxicity. With MAO inhibitors and the selective serotonin reuptake inhibitors, opioids will result in an acute serotonin syndrome, which is characterized by delirium, hyperthermia, and seizures. So at least 2 weeks gap should be given between the two groups of drugs. Serratiopeptidase is commonly used to reduce postoperative inflammation. It is an enzyme, a proteolytic enzyme. It should be avoided in the presence of infection because the infection can become more widespread. It can interact with warfarin and aspirin, thus increasing the risk of bleeding. After analgesics and anti-inflammatory, the drugs that we commonly prescribe are antibiotics, and in that penicillin is the first drug of choice. But if penicillins are given in a patient receiving methotrexate, there can be decreased clearance by the kidneys, resulting in the increased blood levels of methotrexate, leading to their toxicity. However, this is not seen with amoxicillin. So if you have to prescribe penicillin group of drugs in a patient receiving methotrexate, amoxicillin is a better choice. But if amoxicillin is given in a patient receiving allopurinol for the treatment of gout, it can lead to a condition called allopurinol hypersensitivity syndrome, which is characterized by fever, rash, and internal organ damage, which can even be fatal. Next, with cephalosporin, if warfarin is combined, there can be an increased risk of bleeding. If patient is allergic to penicillin, we choose the macrolides, which include erythromycin, clarithromycin. But we have already seen with calcium channel blockers, there can be interaction resulting in a decreased metabolism of calcium channel blockers, resulting in their increased blood levels, leading to dangerous hypotension. This should be borne in mind. This, however, is not seen with azithromycin. So if you have to choose the macrolide antibiotics, azithromycin is a better choice. With statins, We have already seen there will be increase in the statin levels, resulting in diffuse myalgias, renal failure, this dangerous condition called rhabdomyolysis characterized by skeletal muscle damage. Digoxin is taken by patients for cardiac failure, and with macrolides, it results in digitalis toxicity, which is characterized by dizziness and blurring of vision. Clopidogrel is a common drug taken by patients for their antiplatelet activity and cardioprotective activity. There can be decreased antiplatelet action with macrolide antibiotics, resulting in an increased cardiovascular mortality. So we looked at the drug interactions. We will now move on to adverse drug effects seen in dental practice. There are two types of adverse effects. One of them is the predictable effect. These are because of the pharmacodynamic action of the drug, and a good example is gastric irritation that happens with NSAIDs. So when we prescribe NSAIDs to a patient, we very well know that the patient can develop some gastritis. So we can take care and prescribe the patient proton pump inhibitors to take along. So this is a predictable effect. We know that it's going to happen. But certain reactions or effects are unpredictable. We do not know who will develop what kind of effect. And this is because of allergy or anaphylaxis or due to a fixed drug reaction. Good example is erythema multiforme. And if you remember our case 3, the healthy 40-year-old male with 1 dose of paracetamol developed drug-induced Stevens-Johnson syndrome. This is totally unpredictable. We do not know which patient will develop this kind of an effect. So coming to the adverse effects seen in dental practice, we can consider them under 2 headings. The oral adverse effects of drugs which are taken for medical conditions, and the adverse effects which are caused by the drugs that we prescribe or we administer in our practice. We will take up the first one now, that is the oral adverse effects of drugs taken for medical conditions. We all know that mouth is the mirror of the body. So any abnormality in the body often has its reflection in the mouth. So also the drug effects. So we may get to see certain effects like xerostomia, oral ulcers, pigmentation, gingival hypoplasia, angioedema, altered taste, lichenoid reactions, or jaw necrosis, all caused because of the medical drugs which get manifested in the mouth, and patient may present to us for getting solution to these problems. Drug history is extremely important in all these cases to see if there could be a relation between the drug taken by the patient and these oral effects. Now, what you see here is the tongue of a patient with the total dryness of the mouth. You can see the fissuring of the tongue that has happened. More than 400 drugs cause this side effect. And the group of drugs are seen on this slide, range from antidepressants to antihistaminics to decongestants. So most of these drugs, if the patient is put on these drugs, the patient can be told to expect xerostomia. Next is oral ulcers can be caused by multiple drugs that are taken for systemic problems, right? From antibiotics to anti-inflammatory drugs to steroids to antihypertensive, antiretroviral. So a whole lot of drugs can cause oral ulcers. These are few examples of oral ulcers induced by drug. Indomethacin can induce drugs, so also methotrexate, which is an antimetabolite. If you see ulcers in the mouth, and if you cannot put them into the normal ulcers that we get to see, one thing that you have to elicit is the drug history and see if it could possibly be caused by the drugs. Now here I want to make a mention that drugs can induce ulcers in the mouth in 2 ways. One is when they are topically applied, where it is called stomatitis veninata, and when ulcers occur in the mouth due to systemic administration of the drug, the condition is called stomatitis medicamentosa. Oral pigmentation is another side effect caused by multiple drugs. Now this is the picture of a lady who visited our department for this black area in her oral cavity. She denied of taking any of the drugs that are mentioned in this list, but when we insisted on knowing more, She revealed that she was on an Ayurvedic preparation for the last 5 years. We presume that it could be because of the medication, and we asked her to visit her doctor and see if that could be changed. The next adverse effect that we get to see in the mouth is gingival enlargement. So gingival hyperplasia is induced by these groups of drugs, anticonvulsants, calcium channel blockers, and immunosuppressants. So if we do not take the drug history and just do gingivoplasty or gingivectomy for these patients, it is going to come back almost immediately. So it's extremely important that the drug history be elicited, and if there is any chance that it is related to the drugs, then the patient should be referred to the physician or the doctor who has prescribed the drug to see if any other alternative drug can be prescribed for the management of epilepsy or hypertension. Immunosuppressant, generally one will not be able to change. So you will have to manage. So try to do oral prophylaxis and advise the patient about oral hygiene maintenance. Next reaction is lichenoid reaction, which is characterized by lichen planus-like lesions in the oral cavity. It will cause extreme soreness in the mouth for the patient. There will be burning sensation. There can be bleeding from the gums because of the desquamative gingivitis. And a whole lot of drugs can induce these reactions in the oral cavity. So if you happen to see a patient having these kind of reactions, you should elicit the drug history to see if any of these drugs are responsible for the lichenoid reaction. And you can send the patient to the physician to see if it can be substituted with a drug less likely to induce lichenoid reactions. This is a very interesting case that we saw in our department. An elderly lady who came with a complaint of pain on both sides of her lower jaw. On examination, we found some white areas looking like infected root stumps on the alveolar ridges of both sides of the mandible. When we took a panoramic radiograph, it was evident that the bone is resorbed in the area and there is a mixed kind of radiolucent and radiopaque appearance, which is suggestive of osteonecrosis of the jaw. She admitted to using anti-diabetic and antihypertensive drugs with calcium, but she denied of using any drug which was likely to induce osteonecrosis. We insisted on seeing her drug prescription and asked her to bring her drugs, and what she produced was this. She was not only taking calcium, she was also taking calcitriol, zinc, and ibandronic acid. And ibandronic acid is a bisphosphonate, which she was not aware of taking. This is a bisphosphonate. Generally, bisphosphonates cause osteonecrosis when they are given parenterally, but this was an unusual case where for the past 5 years she was receiving this. Every month she was taking 1 tablet of ibandronic acid with calcium, and it has resulted in necrosis of her jaw. So we have to be very careful. If there are patients telling you that they are receiving calcium supplements, it's always better to check. And many times patients just tell you the trade name. So you check from a relevant source whether it also has bisphosphonates, because if you do extraction in such a patient, there is likelihood of developing osteonecrosis. The extraction wound will not heal. So now coming to the adverse effects caused by the drugs that we prescribe or we administer, the most common drug that we prescribe in dental practice is the local anesthetic, and the drug chosen is lignocaine. We know the maximum dose of lignocaine when it is plain is 4.5 milligram per kg body weight. And when it is used with vasoconstrictor, the maximum dose is 7 milligram per kg body weight. But for some reason, if there is exceeding of this dose, it can lead to side effects which may be mild, like tingling around the mouth or some ringing in the ear, but if it can be even severe, like cardiovascular collapse, and it can even be fatal. So please remember this. Tramadol is used in the management of moderate to severe pain. Often we use this in combination with paracetamol, but patients often have these adverse effects: dizziness, drowsiness, nausea, vomiting, and severe headache. and constipation. There are instances where patients have returned back saying they are not able to tolerate the medication. They feel extremely dizzy, where we had to change the medication for the severe pain the patient had. Next group of drugs are the NSAIDs, which we commonly give for inflammatory pain, and they can have different kinds of side effects, which range from gastric irritation to diarrhea, constipation, mouth sores, a feeling of lightheadedness or dizziness, drowsiness, indigestion, hearing problems. So many can be there. So these all can be anticipated in patients to whom we are prescribing NSAIDs. Coming to the next group of drugs, antibiotics. 1 to 10% of the people receiving antibiotics develop one or the other side effect, and most often they are mild adverse effects in the form of nausea, vomiting, or diarrhea. If they are mild, the treatment can be continued, but if it is in the form of anaphylaxis or severe rashes or severe diarrhea, one has to change the antibiotic. Topical drugs, they are relatively safe and don't cause much of a problem, but they are not completely devoid of adverse effects. Like in this case, there can be brown staining of teeth due to chronic use of chlorhexidine mouthwash. However, this is reversible, and with scaling and polishing of the teeth will become white again. This is a secondary effect which can happen when long-term steroid use is there topically, or a patient uses antiseptic mouthwashes for extended period of time. This should be borne in mind when you are prescribing the drug, and tell the patient clearly for how long to use the drug. So we have seen the adverse drug effects. We will now move on to the last part of the webinar, how to avoid adverse drug interactions and effects. I will tell you the important steps to take. First and foremost is to obtain a comprehensive medical, drug, and diet history. We have to spend at least 15 to 20 minutes with the patient, eliciting the medical, drug, and diet history, because we know how important it is to avoid drug interactions and adverse effects. We know that drugs can interact with the medical condition also, so we have to spend some time with the patient and take a comprehensive history. We have to also pay attention to not just the prescription drugs. We also have to ask the patient if they are taking any over-the-counter drugs or they are taking any herbal remedies, because they may also interact with the drugs or with the medical condition that is there. It's also important to update the history on a regular basis. You might be knowing a patient for many years, but the patient might have developed a new condition in the past few days or past few months. So thinking that, oh, I know this patient for long, he is hale and hearty, we cannot take risk like that. We have to take the history every time they come. We have to ask about their medical condition. We have to ask about the drugs that they are consuming. And we have to update their history by documenting it. Keep in mind the risk factors. I've told you about the patient-related risk factors and the drug-related risk factors. Bear them in mind when you want to prescribe any drug, and judiciously prescribe the drugs. Weigh the pros and cons. See whether it's going to benefit the patient. See whether it's going to be of any risk to the patient. First and foremost, we must not do any harm. So prescribe drugs very judiciously and educate the patient about the drug usage. Tell them when to take the drug, how to take the drug, with what to take the drug, what to avoid while taking the drug. Very important to educate the patients about all these things. So it's not just enough to prescribe. It's very important to tell the patient all these details so that there is proper compliance with the drug intake. Then you have to follow the 8 rights of drug administration. We will see what these 8 rights are. So you have to prescribe drug for the right reason. First and foremost, see whether there is an indication to prescribe a drug and whether it is a valid indication. Whether you are prescribing to the right person, is he healthy enough to receive the drug that you want to prescribe? Is there a possibility of a drug interaction or an adverse drug effect? Keep this in mind. Choose the right medication in the right dose. Give it through the right route at the right time and for the right duration. And also look at the response. It's not enough you prescribe the drug and forget about it. Check with your patient whether he's responding to the drug favorably or whether there is any adverse reaction. And also document. If there is any adverse reaction, document it, because it's extremely important that you report an adverse drug reaction. Why we have to report these adverse drug reactions? Because we will be doing a service to the humanity if we do so, because it can be prevented in other patients. So we have to report it to the agency which is taking care of pharmacovigilance. So they will look into the batch of the drug which has caused this, or they will see if there is any component in that drug which may be causing the adverse drug reaction, and they will take measures to see that it does not repeat in other patients. So how do we report the adverse drug reactions? We have to download a form from this particular website. And after downloading, fill it with all the patient details. Please remember here, even patients can report adverse drug reactions. Alternately, we can log on to this website and fill in the details of the adverse reactions, and we can submit it. Alternately, you can also dial a toll-free helpline number, which will receive your the report of the adverse drug reactions. Alternately, you also can download this app on your mobile phones. This is an Android app through which you can submit the adverse drug reaction report. So now you may be wondering, I've told you about so many drug interactions and adverse effects. How are we going to remember all these drug interactions and effects? Don't have to worry. There are now free online softwares available for checking the adverse drug interactions and effects. But you may be hesitant because you may think, what will the patient think about me if I am checking before prescribing? Don't be worried, because present day patients would only be happy and feel reassured that we checked and reconfirmed the dosage and contraindications before prescribing. Tech savvy smart patients would only think, oh, this dentist is also smart. It's better always to be prudent than puerile. These are the URLs of the software. These are relevant and reliable sources. So you can visit any of these and check the drug interactions. Drugs.com is an excellent site. So also Medscape. You have to enter the name of the drug that you want to check and add the name of the drug that patient is already receiving and see whether there could be any possible drug interaction. You can also check the adverse drug effects using these websites. You can also have them at your fingertips by downloading these Android apps onto your mobile. I recommend you do this. I have drugs.com on my mobile. So if there's any doubt, can just at the fingertips, you can check if there is any adverse reaction or interaction. So now I am coming to the end of my presentation. All said and done, yes, drugs are like double-edged weapons. But as long as we know which edge to use, when and how to use, there is nothing to worry. So I would like to reiterate that just because drugs are double-edged weapons, we should not be scared of prescribing drugs to our patients. Drugs are also boon. So we should not allow the patient to suffer because we are scared of prescribing. We should have thorough knowledge of the drugs. We should know how the drugs act. We should know what they will interact with, what adverse effects can be there, and we should know how to identify them and take care of them. So that brings me to some articles which I want to recommend you to read. So you can read this. British Dental Journal has an excellent article, Drug Interactions in General Dental Practice. You can also read this, Adverse Drug Reactions in Dentistry in International Dental Journal. And this is an excellent article which has reviewed top 10 prescribed drugs and their interaction with dental treatment. So at the end, I would like to give this dentist prayer. So, O Lord, please help us all to prescribe conscientiously.
That was a wonderful hearing from you, Kirti. Thank you so much for sharing your expertise with us. We have received an overwhelming response from our participants. Dr. Kirti, do you know how many questions have been posted today? It's around 540 questions. That shows the enthusiasm of our participants. But due to paucity of time, I'll be taking few questions. The first question of the session: does the effectiveness of the drug alters when it is taken with hot or cold water?
Thank you, Dr. Rajeshwari, for the question. I think it's a very valid question. You know, many times we forget to tell the patients how to take their medications. But you know, taking with hot or cold water can be, can reduce the efficacy of the drug, because if you take the drug with hot water, it can alter the physical or chemical properties of the drug, thus hampering its efficacy. And also, if it's taken with very cold water, you know, the body has to spend some energy to warm up that water. So the onset of the action of the drug may be delayed. So I would not recommend taking drugs with very hot or very cold water. Room temperature water is better.
Thank you for sharing, Kirti. This is the common question that has been asked by many participants. How safe are the antioxidants? Because we prescribe them in our day-to-day practice. How safe are they?
Antioxidants. Well, you know, none of the drugs can be considered as 100% safe. So also antioxidants. Antioxidants are very good if they are given for a limited period of time. We do give it in many of the potentially malignant disorders and lesions, but it is better not to take them for extended period of time and in high doses. Because the antioxidants, if they are given in high doses, they can act like pro-oxidants, and they may even protect the cells which are cancer cells. So it is better not to take it for extended periods of time. They are not 100% safe is what I can say.
Thank you, Kirti. Here we have one interesting question that has been posted. During this COVID time, is it safe to prescribe ibuprofen?
Yeah, I think ibuprofen is generally not to be taken in these COVID times, because many have reported that ibuprofen is causing more severe respiratory depression. The exact mechanism by which it is happening is not well known, but there have been reports like this. So I think it is better to not prescribe ibuprofen. Maybe because ibuprofen also, because it reduces the prostaglandin synthesis, it may be reducing the renal perfusion, and the renal system is very important for the whole body to function well. So maybe it is causing some effect which is resulting in more severe disease in COVID patients. So ibuprofen is better avoided.
Thank you for that clarification. Here we have one question on medically compromised patients. Okay, what is the choice of antibiotics in patients with renal or a hepatic disorder?
Right. None of the drugs are completely safe in hepatic and hepatic and renal disease patients, because when there is a compromised liver, the metabolism of drugs will be altered, which will lead to increase in the levels of the drug in the body. So also when there is kidney failure, the elimination of the drug from the body is, compromised. So that may lead to increase in the levels of the drug in the body. So both of which may be toxic. So generally, penicillin group of drugs are okay for both. Amoxicillin is fine for liver failure, but better not to give it with clavulanic acid. So because many times we give augmentin, but better to avoid that. Ciprofloxacin, which is a quinolone, may be given safely in hepatic failure. And in case of renal failure, penicillins are okay. But in very severe renal failure, the nephrologist may want you to, titrate the dose. Instead of giving it 4 times in a day, you may be suggested to give it 3 times a day.
Okay. Thank you, Kirti. Due to paucity of time, I'll be asking the last question of this session. Can we prescribe serratiopeptidase in case of Ludwig's angina?
Rajeshwari, I did make a mention of this in my presentation. You know, serratiopeptidase is mainly used for post-operative inflammatory condition, you know, whenever there is excessive swelling because of inflammation. But if there is, you know, concomitant infection, there can be more widespread infection. So it is better not to give serratiopeptidase in the presence of infection. It can be just restricted to the post-operative inflammation with no infection.
Okay. That's all about question answer session.
Thank you, Dr. Rajeshwari. And I would like to specially thank Dr. Dibyendu Mazumdar, the President, Dental Council of India, Dr. Sabyasachi Saha, the Secretary, Dental Council of India, Mr. Mukesh, Deputy Secretary, Dental Council of India, Dr. Virender Goyal, Professor and Head Pedodontics, Guru Nanak Dev College, Punjab, my moderator, Dr. Rajeshwari Annigeri from Davangere, the entire technical team of Dental Council of India, the Indian Academy of Oral Medicine and Radiology, Dr. Vishal Dang, the past president of Indian Academy of Oral Medicine and Radiology, Dr. Murlidhar Vipai, professor and head OBG, KMC Manipal, Manipal Academy of Higher Education, and my college, Manipal College of Dental Sciences, Manipal, and all of you viewers who have sat through this presentation for the last 1 hour. Jai Hind.
Thank you for that marvelous presentation, Dr. Kirti. DCI has started the live webinars in the month of June 2020, and it has been a great learning experience for all of us. DCI recognizes the top 5 colleges with the highest number of participants. The first one goes to the Saraswati Dental College, Lucknow. Second is the St. Joseph Dental College, Andhra Pradesh. The third place is the Sibara Institute of Dental Sciences, Andhra Pradesh. The fourth is the Indraprastha Dental College and Hospital, Ghaziabad. The fifth one is Guru Nanak Institute of Dental Sciences and Research, Kolkata. Congratulations to all. DCI also acknowledges the participation of other dental colleges and their commitment. The 13th webinar of the DCI series is scheduled on 27th September. That's on next Sunday at 4 p.m. The topic of the webinar is role of magnification in conservative dentistry and endodontics. The presenter of the 13th webinar is Dr. R.S. Mohan Kumar, Professor, Department of Conservative Dentistry and Endodontics, Priyadarshini Dental College. And it is moderated by Professor Sanjay Tewari, Dean, Faculty of Dental Sciences of University of Health Sciences, Rohtak. We request all the participants to register for this upcoming webinar. Also, all the dental colleges to encourage their staff, students, and alumni to participate in the webinar. For today's sessions, all of you have to submit the feedback form that you will receive along with the e-certificate. This can be downloaded from the webinar section of the DCI website. All these webinars can be watched on Webinar Archive on DCI website. I'm glad to inform that we have around 24,600 participants for today's webinar. That is record breaking. That shows the success of DCI webinars. I thank the Dental Council of India, President Dr. Majumdar, Under Secretary Dr. Saha, Dr. Virender Goyal for giving me the opportunity, and I also thank Mukesh ji and other technical staff for their support. My special thanks goes to Indian Academy of Oral Medicine and Radiology and Professor B. Balaji Rao sir for sculpting me. And special thanks to Dr. Vishal Dang for his expert advice. I also thank Bapuji Educational Association for their encouragement. As entire world is going through the pandemic crisis, it is our responsibility to take utmost precautionary measures and serve our nation to the best of our ability. With this, I would like to conclude today's webinar. Live and let live. Stay safe. Jai Hind.